Hello, I'm Dr. Jack West. I'm a Seattle-based medical oncologist and also the founder and CEO of GRACE, the global resource for advancing cancer education. GRACE partnered with the Longevity Foundation to bring you a webinar on immunotherapy for lung cancer. Can we deliver on the promise? This featured my friends Dr. Ramaswamy Govindan from Washington University in St. Louis and Julie Brahmer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland. Each gave a presentation on several topics in immunotherapy that was the subject of a prior podcast. We'll now turn to the question and answer session that followed these talks.
Let's start with a question of, is there any evidence that any of these immunotherapies can get through the blood-brain barrier? Obviously, we are hindered in our ability to treat CNS, the central nervous system disease, and it's a very finite range of strategies we have that seem to have any benefit. Any inkling from either of you that any of these therapies might be applicable to people with brain metastases as a minimally or non-toxic approach that could actually work?
These antibodies, particularly ipilimumab, has some data of potential responses in patients with brain metastasis. Most of it is coming from patients with melanoma, but I know there is a particular interest in the patients with primary brain cancer looking at these type of antibodies combined with radiation therapy, and there's some interesting preclinical data that actually may be synergistic. So I don't think that we have actual patient data to say that, yes, that it truly works, particularly in non-small cell lung cancer, but I think in the future it may be used and combined with radiation therapy.
I agree with that, and I would also add one more thing, that blood-brain barrier is actually breached once you have metastatic disease, just by the very process as well as by the effects of treatment like radiation. The challenge in my mind is, will these drugs work? Will immunotherapy or specific immunotherapies work in lung cancer? Who are the patients who would benefit from what therapy? Again, saying immunotherapy broadly doesn't do a good justice here. There are different kinds of approaches, going after the surface proteins, removing the brakes, and stimulating selected parts. These are very different approaches conceptually and practically. Which one of them will work? And even if one or two out of this alpha doesn't pan out, we need to identify the specific groups of patients who benefit the most, who benefit very well. And once we identify the group, I think the next step, will it work in brain versus lung versus other organs, would be a little less of a concern, at least in my mind. But I think we have to wait for the next 3-4 years before we understand better where they all fit in.
Thanks. Another question came in about, have any of the vaccine approaches been studied in combination with a targeted therapy, a maintenance-type therapy such as erlotinib, EGFR inhibitor, because these could potentially be integrated?
Absolutely. I think the approach so far that has been taken with drugs like erlotinib is, we clearly know that these tumors are addicted to this EGFR pathway. We've also understood very well that at least in half of them, a single mutation actually makes the drug ineffective, and in about 20% of them, a different pathway get activated. So how do you tackle these two problems? We understand why these cells no longer respond to erlotinib. And in one instance, a specific mutation happens. Essentially, you come home, your key does not open the lock because your lock has changed. How do you find the best key for that lock? I think that's a correct approach to pursue, but it is not to say that we cannot pursue immune therapy. I think right now we understand the mechanism, but we just have to get the right drug to develop to tackle that activation of that pathway, because without a question, these cancers are driven by the EGFR in that specific group of patients who have EGFR mutant disease. In terms of the other targeted therapies, I am unaware of any combinations that are being pursued, but I also would be disappointed if I learned that there are some combinations. I think we have to understand the science better at the moment.
So a question came in, and I think it does merit some further discussion, on clarifying a comment that I think that you made, Govindan, about that these agents are more likely to be effective, these immunotherapies, for patients who have controlled disease, potentially earlier stage disease. And yet we are seeing, and we saw several agents that are being tested in advanced disease, Can either of you comment on the place in the course of treatment where these immunotherapies are more or less likely to be used and effective, whether in the setting of progressing disease or really should be relegated to minimal residual disease or a maintenance setting?
In terms of the three agents I talked about, the Leukonex vaccine, the MAGE-A3, and the one directed against MUC1, and those are the way current studies are designed. They are given after some primary therapy. MAGE-A3 after surgery, the MUC1 directed therapy after chemoradiation, and similarly after chemotherapy for the Leukonex. And so there, the primary therapy is not vaccine. Vaccine therapy is used more in the maintenance fashion. But then, as Julie mentioned, there are other agents that can be used directly as monotherapy. So I'm not saying that immunotherapy will never be used as a monotherapy, but I think at least the three agents I talked about, they are being done in the maintenance setting. I don't get a sense that the MAGE-A3 or Leukonex or the MUC1 would by themselves be active as monotherapies. I'm just curious to hear your thoughts, Julie.
Yes, I would agree with you, Govindan. I think most of these agents, the ideal setting to have potentially the greatest impact for the longest disease control would be either in the adjuvant setting or maintenance setting where the tumor either has been removed or radiated or controlled with chemotherapy. However, I think some of these agents do have a hint of single-agent activity, and so certainly, but particularly for those in that setting, such as in the metastatic setting where there's active tumor in place, I think, like Dr. Govindan had said, we need to really identify the patient population that can respond to those type of therapies, and I think that's coming in the near future.
We've heard about dendritic cell therapy as a vaccine platform in other cancers. Did not hear about that. Any awareness that this is being pursued in the setting of lung cancer or not at this point?
Not that I know of. I mean, certainly there have been attempts to do patients' own tumor-based vaccines, but they have been very difficult in patients with lung cancer.
One last question we'll finish with, and that is, there was a lot of news about the immunotherapy that was studied at the University of Pennsylvania for leukemia with a vaccine that was referred to as a genetically serial killer T cell. Any idea whether this kind of work is being explored in the setting of any solid tumors or lung cancer in particular, or is that, as far as you understand, going to really be explored far more in leukemia before it finds its way into a solid tumor setting?
I think it's a fascinating approach, but to the best of my knowledge, it's not being tested in lung cancer. Again, remember that's based on a very small number of patients. But I think that needs to be identified, and the disease model like lung cancer may not be perfect or suitable for that at the moment, but at least it has to be confirmed in leukemia first before we move forward with anything else.
Correct.
I do think, one thing is that for years there had not been a lot of optimism about the entire approach of immunotherapy for solid tumors, or at least outside of melanoma or renal cell, and now we're starting to see much more. And if we see any positive results from some of these larger trials that are likely to be presented in the relatively near future, some of them that you talked about, Govindan, are ones that we should be hearing about within the next year or two. If they demonstrate a utility, then I think we will see a remarkable increase in the enthusiasm for further study of a lot of these agents, and that might even start with some of the work that, Julie, you alluded to for presentation at ASCO. But clearly, I think people are encouraged by seeing early successes, and we might see a much greater level of interest in the next decade than we've seen up to now.
I agree. Jack, if I can make one more comment along those lines. I know that a lot of patients and family members are listening to our conversation, and I cannot imagine how anxious they must be. Science progresses sometimes in its own stately pace, but I have to say, and I'm curious to know what you two think, I've never been more optimistic with regard to cancer treatment in general and lung cancer treatment in particular. 15 years ago when I began this, we had very little options, and today we have so many options. And I think in the next several months to some years, you're going to be seeing a lot of new drugs being in clinical trials. And I think I would encourage our patients and families to be on the lookout, talk to the doctors, to identify some clinical trials they'll be suitable for. And I really think getting people in the right trials is the right thing to do. But it's a long work, it's a challenging work, but I think the scientific technology is improving at an amazing pace, and I'm more optimistic than ever before.
I certainly share that. I think it's a very gratifying time to be working in the field of lung cancer, and to an extent just cancer oncology in general, because while we're seeing with this new world of molecular oncology that there's so much more under the surface than we had appreciated, we're picking up speed as we learn more and more. And to see agents like crizotinib, Xalkori, approved after the target was just identified a few years ago, to see new targets being identified every few months in the lab and getting translated to clinical practice, and to have new agents and approaches becoming darling concepts from one ASCO to the next is remarkable. It's gratifying to think that 5 or 10 years ago there was all too much cynicism and pessimism about the field of lung cancer reaching a plateau and never moving forward, and now we have the champagne problem of a dizzying pace of progress. And I think it creates a situation where it really behooves patients and caregivers to try to keep informed about all these opportunities, because some of them, there can be a real gulf between the time when the first people are hearing about and potentially benefiting from these, especially in a trial setting, and when they become available to everyone else later down the road.
Right.
Well, that's the end of our time tonight, but I'd like to thank all of you for joining us, and I'd like to offer my huge thanks to our wonderful friends who served as guest faculty members tonight, Drs. Ramaswamy Govindan and Julie Brahmer. I'd also like to thank Longevity Foundation for working with Grace to make this program possible. So thank you all, and have a great night, everyone.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts and the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.